My name is Donna McKay, and I'm the Executive Director of Physicians for Human Rights. I'm told that we have nearly or more than 600 people registered for today's discussion, many of whom are health professionals who are working to beat back the pandemic, as well as many others who are policymakers and advocates working aggressively to address the numerous inequalities that this pandemic is revealing and exacerbating. So thank you so much for taking the time to join this discussion today. Before I turn it over to Dr. Bob Lawrence, I first want to acknowledge all of my PHR colleagues, the staff and the volunteers, the board leadership, and our many, many partners. As the COVID-19 pandemic has escalated, the expertise and insight of PHR and our network of medical, public health, and other scientists has been in extraordinary demand, probably more than any time in our history. We've been fielding urgent, nonstop requests from the media for expert analysis on the pandemic's impact on various people in vulnerable situations, a key situation which we'll be talking about today, responding to many requests for collaboration and consultation from partners in the global NGO fields who are seeking expertise of health professionals for their policy efforts related to COVID-19, and just the general public's unprecedented hunger for reliable information from a trusted source. As we continue to endure the impact of the COVID-19 pandemic, PHR is helping to elevate the voices of health professionals and scientists to make sure that they're informing and leading the response. So much of the contours of this pandemic are still unknown, but we do know that the coronavirus pandemic has brought hunger to millions more people around the world. Honestly, it's hard to imagine a health and human rights crisis more urgent, especially for poor people, those struggling before the outbreak and have relatively no safety net. Food insecurity in the US is a chronic issue and has only been exacerbated by the extreme health risks and the economic fallout brought on by COVID-19. Already, we know that there are 37 million Americans struggling with hunger. And as unemployment soars and families are struggling across the country and our food banks are facing unprecedented demand, this situation will obviously exacerbate. Medical experts and researchers and advocates have put the issue of ensuring Americans are fed as a primary focus in their response, thankfully, because it's really difficult to imagine a greater important issue to focus on today. So we have the pleasure of benefiting from the expertise of medical experts and scholars who've dedicated their careers to addressing food insecurity in the United States. Their work and insights have become critical at this juncture as COVID-19 has worsened an already dangerous situation for communities at risk. So today they will help us understand the issue and discuss what can and must be done to address it. We welcome your questions throughout today's briefing. So please send those questions to webinar@phr.org or submit to the Q&A box that is on the Zoom, and we'll do our best to address them later in the session. So I'm thrilled to introduce our moderator, Dr. Bob Lawrence. He is a PHR founder and PHR board member emeritus who previously served as our board chair. He's also currently the Center for a Livable Future Professor Emeritus at the Johns Hopkins Bloomberg School of Public Health, which he also founded in 1996 and served as its director until 2015. So as you can see, Dr. Lawrence is a visionary when it comes to seeing the world's inequities and ways to address these with the unique lens of medicine and science. Dr. Lawrence currently sits on the board of Socially Responsible Agricultural Practice, a project, and has previously was the Epidemic Intelligence Service Officer at the CDC. So I'm going to turn it over to you now, Dr. Lawrence, to introduce our panelists and get us started. I'm going to take myself off video and return at the end. Thank you.
Thanks, Donna. Welcome, everybody. I appreciate your tuning in today, and I am delighted that Dr. Hilary Seligman and Dr. Kofi Essel have been able to free up their busy schedules to join us. Before I introduce them specifically, I just want to pick up on what Donna said about the global situation. In preparing for today's session, we decided that trying to do both domestic US situation and the global situation would be too much for 1 hour, probably too much for several hours. But just to put it in context, the FAO, Food and Agriculture Organization, World Food Program estimates that there are now an estimated 265 million additional people, or rather, we will double to 265 million people living with food insecurity and hunger globally as a result of the COVID-19 pandemic. Here in the United States, we are seeing already manifestations of our share of that problem. The interesting thing to me is that people worried about the virus are confusing food security with food safety. And I just want to very quickly read what the Food and Agriculture Organization says about food security, which is the topic of our discussion. Food safety is really not an issue for us in terms of the virus being able to survive in our food. Food security exists when all people at all times have physical and economic access to sufficient, safe, and nutritious food that meets their dietary needs and food preferences for an active and healthy life. So when we hear from Hilary and Kofi about food security issues in the US, that's what we're talking about. Now, before I ask Kofi to kick off and before I introduce him formally, let me just also say that the COVID-19 pandemic is bringing out, in a way that very few other things have, the enormous impact of the social determinants of health: food security, housing, shelter, an income that allows people to pay their utility bills, to see medical professionals, and so forth. And it's a dilemma for many, many Americans now who were living paycheck to paycheck to face the dire consequences of loss of income. They're going to be making and are already making trade-off decisions about feeding their children versus keeping electricity on. So that's a very important part of what we think this pandemic is highlighting. The food, social determinants of health have been a topic of intense investigation for 30 or 40 years, including some of Hilary's work. And it now is being shown in such a clear way that I would hope, after we control this pandemic, that there will be a greater awareness and ongoing attention to how critically important the social determinants are. We're going to begin with Kofi Essel, who is nationally recognized in the area of food insecurity. Kofi is an assistant professor of pediatrics at the George Washington University School of Medicine and Health Sciences, where he directs their community urban health scholarly concentration and the Clinical Public Health Summit on Obesity. He's a community pediatrician at Children's National Hospital in Washington, and as I mentioned earlier, his practice site is in Anacostia. He's in the previous year, the National Minority Forum named Kofi among the under 40 leaders in minority health for 2019. Please, Kofi, proceed and let us know what it's like on the ground in DC.
Excellent. So thank you all for having me today. I'm going to spend a few minutes just talking about my experiences as a community pediatrician and the families that I see. As a community pediatrician, I get the opportunity of working with families. And I think it's important to understand the lived experiences of families as we paint the context of our discussion today. So let's talk about how families experience food insecurity per the data and per anecdotal experiences as well. The way I like to look at this is sort of in 4 steps. The first step we often think about with the experience of food insecurity is something that we call food anxiety. Food anxiety is constantly a preoccupation or perseveration of where is my next meal going to come from. That is something that people often talk about when they have shortages of food or experiences of food hardship in particular. The next step we think about after food anxiety is this concept that we call a monotony of the diet. the diet begins to decrease in its variety and its quality as well. This is when you start to think about the association. Some people associate obesity and food insecurity, and those ties are interesting, and we can dive into those. But in particular, you think about higher caloric density foods, lower nutritional value, right? Foods that are more simple to make, things that I don't want to waste my money on, right? Because if I waste my money on certain foods, then there's a chance that I or my children may not eat these foods. So why would I spend my money on those? And of course, it just simplifies our bandwidth, our ability to focus on different things. So in particular, we talk about the monotony of the diet as the next phase. The next phase after that is when we start thinking about a decrease in intake of adults and children. In particular, adults will do everything they can to protect their children from experiencing food hardship. So in particular, the adults' intake begins to decrease first. And then the last step is children's intake begins to decrease. All right. So when you're experiencing children's intake decreasing, we sometimes associate that with more worsened degrees of food insecurity. Something we also attach to that is this concept of accepting foods or getting foods in socially unacceptable ways. This tends to be a more extreme degree of food insecurity as well. And that definition of unacceptable ways really depends on the family and the individual, but these can be emergency foods. It can be using bartering techniques. It can be selling one's body. People will do all kinds of different things that they may not have done before in order to access food, to care for themselves and their families as a priority. Now, in general, parents will say they're protecting their children, and children don't know about food insecurity in their household. They feel that, hey, I don't tell them what's going on. I let them eat first. I'll starve so my child can eat. But in reality, the data shows us that children actually know what's going on a lot of times. And in fact, older children will often decrease their intake so that their younger siblings and their parents can have more nutritious foods as well. So that's sort of a response to food insecurity that we often see in the household. One of the questions I often ask is, what is sort of these coping behaviors? Hilary does a great job with really highlighting the coping behaviors to food insecurity. And one in particular that we often talk about is a decrease in cognitive bandwidth. How can I shift and focus on a variety of different things if the toxic stress of being food insecure or living in a food insecure household is unrelenting, right? The ability to shift on my medicines to take, getting to appointments, to do all these other things that need to happen is limited, is hindered. A temporal discounting process begins to occur. And that's something we often see commonly. So how do we identify this? Well, of course, in the clinical realm where I work, there are a variety of ways of identifying this. And the most common ways when you ask people across the board as clinicians is really looking at anthropometric findings. So looking at weight gain or weight loss, maybe looking at labs, anemia, looking at iron deficiency before you even get to anemia. You could even talk about looking at other clinical exam findings, stress, other behavioral traits that people may notice. But the reality is the most common symptom is nothing. It's invisible. Food insecurity is often described as being invisible. And one of the things that we're seeing now is the invisible is becoming quite visible because we're becoming more aware of people's distress and hardships. And I think that's something that we need to identify as well. Last thing I'll just quickly highlight is sort of what are some things that have been changing as a result of COVID-19. So one of the things I think about with COVID-19, initially, I was thinking about COVID-19 as being what I call a great equalizer. You started to see the effects of COVID-19 across the board, prominent actors and actresses, royalty, prime ministers, high positions of government all around the world. As we stared more and more, we started noticing something else. COVID-19 began to be a great magnifier, really magnifying disparities that existed all along. So just as we clearly can identify a cause and a reason that has sort of triggered and led to individuals' hardships that they're experiencing, families, children, individuals in general, we have to remember with disparities, there are clear systemic inequities that have led to these hardships and these social determinants that we are experiencing even to this day. Now, the reality is with food and with hunger, we can't address hunger, food insecurity with just giving more food. We have to think about these underlying conditions. And we're going to be elaborating more on this as well today, but I'll pause there so Hilary can jump in.
Okay, thank you. I'm sorry, I wasn't sure if Bob was coming back on. Thank you, Kofi, for teeing that up so nicely for me. We know from a lot of research that food insecurity is a really important risk factor for chronic illness and for disability, and in turn that illness and disability are really important risk factors for food insecurity. We are seeing now massive increases in food insecurity rates across the United States that we foresee as having really negative implications for population health over the coming years, because the behaviors that get set up during acute times of food shortage can often persist for years and years and years. And the economic conditions that are being set up right now make it likely that people who are experiencing food insecurity now for the first time or chronically coming into this crisis are likely to be experiencing it for decades to come, for years and years to come. So these create an environment in which we have to really be worried about the negative health implications that are going to come from food insecurity on population health more broadly. Now, the typical food insecure household relies on many resources to meet household food needs. Kofi talked about some of them. In the interest of time, I'm just going to focus on two: federal nutrition programs and community food support, or the charitable food system. And really, I'm going to try to highlight what policy things have changed and what programmatic things have changed over the last 6 weeks, where we're seeing incredible innovation unfold, and what real challenges we have for the future. I'm going to start by focusing on two federal nutrition programs, SNAP and the National School Lunch Program. SNAP, or the Supplemental Nutrition Assistance Program, used to be called by the name food stamps. This is one of the two largest anti-poverty programs in the United States, the other being EITC, the Earned Income Tax Credit. As you know, the Earned Income Tax Credit is only for households with income. So SNAP has outsized impact on all households that are living with low incomes, but particularly for those that do not have any income. SNAP benefits come on an electronic card, like a credit card, that can be used to purchase food at authorized food vendors. And what's really important to understand about SNAP is it's what's called counter-cyclical. SNAP is able to massively scale up when the economy turns down. And SNAP benefits are spent immediately, generally within the first couple of days of arriving on one's SNAP card, which means that the money that's spent by the federal government on SNAP benefits makes its way into local communities almost immediately, which has a positive impact on local economies and helps to blunt the recessionary forces. So we have in fact seen that SNAP has massively scaled since the pandemic hit. There were about 36 million people enrolled in SNAP before the pandemic hit. In one of the first stimulus packages, about $15 billion in additional funding was allocated by Congress to the SNAP program to cover the newly enrolled. This is important because SNAP is an entitlement program. All citizens of the United States who meet eligibility criteria are entitled, as part of their benefits of being a citizen, to SNAP benefits. So that's one important thing that's happened. Two other important things that have rapidly happened. One is the implementation of what is being called pandemic EBT, or PEBT. This adds the value of school breakfast or school lunch onto the SNAP card so that meals can be purchased at a store to replace meals missed during school lunch. And there's also been massive innovation and dissemination of SNAP use online. It was formerly in its pilot stages in 2 states, and now more than 13 states have been approved by the USDA to convert SNAP utilization, to allow SNAP utilization completely online, mostly at Walmart and Amazon, but also at other local food retailers. So this is all good news, but there are challenges. Not everyone is eligible. Undocumented populations are not eligible. There are income limits in some states. There are other eligibility criteria like asset limits and prior drug felonies. There's also a big need to increase benefit levels. Even pre-pandemic, there was real consensus that SNAP benefits were not adequate. They were based on a highly outdated formula. And so there's been real movement to include in the next stimulus package a rise in the minimum benefit level from $15 to $30 a month, and to increase benefits for everyone by about 15%. So lots of innovation has happened in the last 6 weeks, but also a lot of challenges. The National School Lunch Program is another federal nutrition program that has had a lot of movement over the last 6 weeks. 15 million breakfasts and about 30 million lunches are served daily at low or no cost to low-income students in the United States. And with sudden school closures, households lost access to all of those meals. We know that, that this has an enormous impact on food insecurity rates. We know this from, for example, the summertime experience. Food insecurity rates tend to spike in the summertime when children don't have as reliable access to those school meals. So there's also been rapid innovation to try to fill that gap. School buses delivering food on their typical route instead of picking up students. Meal delivery in alternate locations like in libraries or parking lots and community centers. But again, there's been enormous challenges. It's not easy to shift rapidly your meal production from serving in a school cafeteria to repackaging food to go. There's been lots of challenges in distributing food in bulk and getting packaging and different meal plans. And then of course, there's the challenge of implementing social distancing at distribution sites and concerns about the safety of school nutrition personnel. We don't know how many meals have been replaced by the innovative efforts that have been going on and by pandemic EBT, but experts think we're up to about 20% of school meals are being replaced in local communities, which has been a tremendous success. I'll turn now to just a couple of comments about the charitable food system, which includes food banks and food pantries, as well as soup kitchens known as free dining rooms and home delivered meals. For food banks and food pantries, this has really been the perfect storm of many combined challenges for both clients and for the food system, which really collide at the food bank and food pantry. Acutely, when shelter-in-place orders went into effect, the system suffered a number of simultaneous hits. First of all, many food pantries closed when all other businesses closed because they weren't able to quickly implement appropriate social distancing policies, and volunteers were sheltering in place as well. Volunteers also make up a tremendous amount of the workforce that the system relies on, not just at the food pantry, but at the food bank, where the food is packaged and sorted and distributed to food pantries that actually reach people. And finally, the food donation stream was tremendously altered almost overnight. And this was primarily because there was this enormous reduction in the amount of food eaten in restaurants and schools and work sites, and a shift to all food purchases being through grocery stores, which led to shortages in the retail setting and shortages in food packaged and labeled for household use. So for example, if you can imagine in the school lunch setting, you can't just take one of those big bags of milk that's meant to fill a milk dispenser in a school cafeteria and send it to a household. And you can't immediately redo that milk production line to put the milk into gallon containers. And so large donation streams from the retail sector dried up overnight. And even while producers and manufacturers were throwing away food because it wasn't appropriately labeled and packaged for household food use, it couldn't initially be diverted to food pantries and food banks. Again, enormous innovation happened. Food banks established pop-up distribution sites almost overnight in many communities. And in some cases, thousands of households are showing up to these pop-up food bank distribution sites to receive pre-packed boxes of food. Again, an enormous change because this is not the way that food is often distributed in food pantries in 2020 through pre-packed boxes. The typical food pantry in 2020 looks more like a grocery store. So enormous changes in distribution that has required immense volunteer effort, in some cases supported by the National Guard. This has created new shortages, for example, shortages of cardboard boxes needed to do that. There's been also tremendous innovation in how to implement social distancing policies in the pantry setting. And even in many communities, the overnight development or expansion of home delivered grocery programs for people at highest risk who couldn't really leave their homes. So the system is stretched to the limit. There have been mass increases in demand and huge reductions in supply at the same time, as food banks and food pantries are reaching clients at the highest risk of COVID exposure and complications, not only because people tend to be chronically ill and disabled, or to have chronically ill and disabled people in their household if they are food insecure, but also because low-income households are working in many of the jobs that are essential and continuing during shelter-in-place orders, like nurses' assistants who are taking care of patients on the front lines, and meat packers that have received so much exposure lately. So in conclusion, enormous increases in food insecurity, and if these are not addressed, many of the downstream implications of food insecurity will be born in the healthcare setting. We know that from a lot of research done pre-pandemic. And the lessons we learn now can be really important for how we as a country learn how to better address food insecurity in the future. So my hope is that much of this innovation will give us the lessons learned to better create programs and policies that will address food insecurity in the future. So with that, I will turn it back over to Bob, and thank you for the opportunity to talk with you guys today.
Thanks very much, Hilary. And my apologies, my computer would not allow me to unlock the mute. Almost like some of my children, I think, would wish to be able to do that. So Hilary Seligman, as you've now heard, you won't be surprised to know that she's a nationally recognized expert in food insecurity, professor at the University of California, San Francisco, with joint appointments in medicine, epidemiology, and biostatistics. Hilary directs the Food Policy, Health, and Hunger Research Program at UCSF Center for Vulnerable Populations and the CDC's Nutrition and Obesity Policy Research and Evaluation Network. Hilary also founded Eat San Francisco, or Eat SF, a healthy foods voucher program for low-income residents of San Francisco, and she serves as Senior Medical Advisor for Feeding America. So thank you, Kofi and Hilary, for setting the stage. I want to go back to something Kofi said about the problem within families of the parents refraining from food in order to feed the children first. And it reminded me, although we're focusing on domestic issues, do you think you might begin to see some of the dual burden problem of malnutrition common in low-income countries, where the older people are obese because they're eating cheap, high-fat, high-sugar processed foods, and the children are protein malnourished because there's basic food insecurity for the entire family, but it's manifest in different parts of the life cycle?
I think that protein malnutrition is a very severe form of hunger, right? Of malnutrition that takes a long period of time. Even with the nutrition we eat, vegetarians, ovo, lacto vegetarian, whoever you're talking about in general, people tend to get enough protein in this country for a variety of different reasons. It looks right now that that will be okay. In terms of obesity and food insecurity, the population we see it most commonly with, overlaid with, tends to be middle-aged women in particular. We don't tend to see that association across the board with everyone. We see some anecdotal reports here and there. The reports are pretty mixed. We see some associations with obesity and food insecurity, some showing no association, some showing actually an increase in weight loss with food insecurity. So it's kind of mixed and it's kind of hard to tell. In particular right now, with an increase in processed, highly processed foods and people intaking these foods because of its long shelf life and people easier to purchase and the accessibility of these foods, I mean, it makes sense for us to see that trend over these next coming months. But it really depends on what we will see over these next coming months around the changes around COVID-19. But there's a very high likelihood that we could see that.
Related to that, Hilary, are there any data suggesting that the SNAP recipients and SNAP beneficiaries who run out of SNAP money early in the month shift then to less healthy, highly processed foods high in fat, sugar, and salt?
We know overall, not just in SNAP households, that there is a cyclic pattern to dietary intake in very food insecure households. We see this most among mothers for reasons that Kofi described, where dietary intake, overall caloric intake goes down at the end of the month. Micronutrient intake goes down at the end of the month. And this is because these healthier foods are more expensive. And so certainly we see that pattern. Now, the next question is, do SNAP recipients overall have better diets than non-SNAP recipients? And I think the answer to that question is complex and starts with nobody in this country at a population level has a very good dietary intake. Our dietary intake as a country is very, very poor. And in that context, the SNAP recipient's dietary intake is also very poor. But what we know is that when a household that is eligible for SNAP enrolls in SNAP and their food budget gets better, their food budget goes up, dietary intake improves in terms of the healthfulness of the food that people are able to afford. And so this is one reason why we think SNAP is such an important mechanism towards addressing food insecurity in the United States, is because it allows households to afford more expensive foods, which tend to be healthier foods.
Mm-hmm. I'm reminded of that years ago when the neighborhood community health center program was just beginning under the Office of Economic Opportunities in the late 60s, that food insecurity and hunger in America was much more front and center, and clinicians attempted to actually write prescriptions for healthy food under Medicaid, and that was, of course, rebuffed, but it created a political dynamic that led to an improvement in the food stamp program first, and then the supplemental nutrition assistance program. What do you think and this is really for both of you, I'll start with Kofi, what do you think the exacerbation of food insecurity in low-income neighborhoods like Anacostia will do in terms of modification, expansion of either SNAP benefits or something direct to food pantries and food banks to increase access for poor people?
I think that's a great question. I think that it depends on the population, right? So the population that's being affected in Anacostia, where I work in DC, it's a very marginalized population. As long as we are recognizing the disparities that led to some of the food insecurity that is actually enhancing now in these communities, as long as we recognize that and allow them to be part of that decision-making moving forward, I think it's gonna bring a lot of voices to what's happening in the community and actually sort of the changes that we're gonna want to see in those communities as well. At the end of the day, I think that the federal government, I think that really laxing, like Hilary was talking about, putting down a lot of these restrictions around WIC and SNAP and allowing for more flexibility has really enhanced my family's ability to connect with food resources. That has helped because they're not able to come in the clinic as much, they're not able to come into the WIC sites as much, and that's been a great help. The question is what happens after this period of time? Are we able to continue some of these innovative and rapid changes, or do we kind of go back to our slower process in addressing some of these needs for these highly marginalized and highly, these communities that really need this assistance?
Hilary?
And I'll add to that we have seen a little bit of innovation here around Medicaid funding some of this work to allow people better access to healthy food. Massachusetts would be a good example of a state that's done a really good job of using the Medicaid waiver process to help support this work. Another area of innovation is actually coming not through CMS and the Medicare Medicaid process, but through the USDA. The last Farm Bill made permanent a program that's now called the Gus Schumacher Nutrition Incentive Program that allows grantees to develop produce prescription programs that really try to link the healthcare setting through some kind of prescription or voucher or token or incentive to the retail sector, where they can purchase at farmers markets or grocery stores or corner stores healthy food, generally fresh fruits and vegetables. This is an example of another way in which we've tried to put policies in place and put financial resources around mechanisms to better connect people in the healthcare setting with healthy food they need to prevent and manage chronic disease.
Mm-hmm. Your program, Eat SF, is the kind of supplemental SNAP benefit, it sounds like. And I suspect it's somewhat unique to a community that is as progressive in their thinking as San Francisco tends to be. What are the chances of generalizing that to a place like Anacostia?
Well, let me back up a minute and say Eat SF actually is not part of SNAP. You do not need to be enrolled in SNAP to receive Eat SF vouchers. There are local voucher programs similar to Eat SF that provide money redeemable for fresh fruits and vegetables in communities across the United States. Many of them are funded, again, by the USDA GusNIP program, and many are supported by local funding and foundation funding. And any local community that wants to put their own resources towards this sticky problem, and in many cases, the communities are coming up to the plate because they're interested in better supporting population health outcomes. Any local community can set up one of these voucher programs. Now, I do want to call attention to one important thing that comes from the questions. One of the attendees asked about the immigrant community and how the immigrant community has been disproportionately affected by this crisis and has been disproportionately affected in terms of food security because of the public charge issues that created motivation to disenroll from SNAP and WIC in the months and the years leading up to this pandemic. One of the things about food voucher programs that make them very appealing is that they are not subject to all of the constraints of SNAP and WIC. Depending on their funding, of course. And so local communities can choose who they want to tailor their programs toward. And in many places, like in Eat SF, we have made real efforts to try to bring the undocumented community under the umbrella of Eat SF because they have such reduced access to some of these other federal nutrition programs.
Mm-hmm. And in the immigrant community, Kofi, the challenge for being sure that children have access to adequate food is particularly exacerbated if they're not eligible for other benefits. Have you had any engagement with that issue?
Yeah, I think one of the biggest things that pops up that I'm seeing anecdotally is with the public charge, with the fear being out there, what's happened is it's pushed a lot of our families away. In fact, they don't feel welcomed anymore as much as they did before. So what's happened is you've seen the federal government sort of put out reports, USIS, mentioning, hey, if you are getting tested, if you're getting screened for COVID-19 and these different things, it won't be held against you. But I think the fear has already been out there. And so I'm seeing my families not really trying to take advantage of SNAP as Hilary mentioned, even though it was a very important role for their family prior, but now they recognize it's not going to be something they want to invest in because it can affect their future. And also recognizing their children, right? So now that their children are out of school, it's harder for their family to be able to maintain the food to be able to supply for their children as well, because, you know, a lot of our kids are receiving up to 2/3 of their meals from schools, right? So this has been a big hardship that we have seen in our clinical settings.
Hilary mentioned that 20% of that lost food school lunch program, school breakfast program has been restored. What are the probabilities that we're going to see a big increase in that kind of food assistance?
It's a very challenging thing to get school meals to kids when they are not in school. But states have done remarkable, or school districts have put an enormous amount of effort into this. And there is, as I said, tremendous innovation. I don't think we will get to 100%. But I think school districts are showing higher and higher levels every week of the number of kids that they are reaching. And we're learning every week how to do it better and faster and more efficiently. And so hopefully over time, we'll get closer and closer to making up those missing meals.
Mm-hmm. I'd like to turn for a moment to the plight of people in the supply chain. Of course, in the news, we're seeing a lot about the plant closures for particularly pork and beef. And many of the workers in those plants are undocumented immigrants. They are suffering high rates of COVID-19 infection, tremendous impact on their households because of loss of income when they're out sick. Is there a way of framing this issue for us to try to create the political will that post-COVID-19 we will recognize that the food workers that harvest our food, that process it, that deliver it to the grocery stores and so forth, they need the protection of paid sick leave, they need the protection of subsidized childcare, all the other things that would make them enter into a more secure job situation and thus protecting the security of our food supply. What do you think the odds of that are?
I will give you a not quite perfect response. One is, I think that this pandemic is highlighting how critical our food supply workers are to our national security. And there are many people, many policymakers who are much more intent on securing our national security than they have been intent on addressing disparities in health and socioeconomic disparities. And so maybe that highlighting will help create some political will. I want to just focus on the fact too that we're really uncovering here, and I think Kofi said something similar, we are really uncovering here structural inequities across the US. They are just becoming more apparent to us. The people who are working in these food distribution plants, the meat packers, the people harvesting our fruits and vegetables, are people who have been largely marginalized and are largely not able to take advantage of many of the social supports that have been put in place in the United States because they've been inaccessible. And so if we are really going to solve the problem of food insecurity, and one of the panelists asked the question about what are the root causes, we really have to fix these structural inequities that are primarily impacting Black and Brown households. And we are seeing that come to the forefront over and over in the COVID crisis, both with our food supply workers, but also in the numbers of people who are Black and Latino who are dying of COVID-19 compared to people who are white.
During my training, the only patient that I ever diagnosed with scurvy was an elderly woman living alone who we had a nickname for these people, not very charitable as in retrospect, but part of the Black humor of intense residency programs in my day. And that was, they were called tea and toasters. So they drank tea and they ate toast, and they had multiple micronutrient deficiencies because They were living alone, had no support system, and she came in, presented to the emergency room with bleeding from the gums and a few other problems, and something went off in my head to draw a Buffy coat vitamin C level, which came back very, very low, and so she was diagnosed with scurvy. But it's a dilemma of the current food insecurity in the COVID-19 pandemic that Black and brown people and also the elderly are a special risk. And the elderly, many of them do live alone. Many of them are fearful, and in fact, in many states, told do not go out grocery shopping. They can't afford the delivery costs of various responses that other middle-class people are willing to pay in order to get safe food that is going to not endanger their exposure to COVID-19. So I wonder, both in California and in DC, whether you're seeing particular challenges for getting food to people who are unable to leave their homes, especially the elderly. Kofi, do you want to talk about that in your community?
Yeah, so I think Hilary kind of highlighted it as well. I think that we, in DC in particular, we're divided into 4 quadrants and 8 geopolitical regions we call wards 1 through 8. We call our wards 7 and 8 is east of an Anacostia River. And you see sort of what we call a tale of 2 cities. In particular, wards 7 and 8 have about 80% of the low food access areas in the whole of DC. So we see these disparities there. There's only a few grocery stores, and these numbers haven't really increased too much. Disparities are really, really clear in these areas. I think in particular, the question is, how do we address these more effectively? And I think that in general, through the clinical realm, we are doing a better job of screening across the board, and trying to make sure that through our screening practices, we're consistent, and not using our own sort of biases to be able to judge if someone is struggling with food insecurity or not. A tool that we use quite frequently is what we call the hunger vital sign. If you take the 18-question gold standard screening tool that the USDA uses every year to screen for food insecurity, it's those first 2 questions. These first 2 questions have pretty good what we call sensitivity and specificity in being able to diagnose a family or an individual household who's at risk for food insecurity. When we identify this, we try to make sure we connect them to meaningful resources that they can find around them. To be innovative is really important right now. Families can't always get to those grocery stores because they don't exist. Farmers markets are starting to ramp up. We have a group called Fresh Farm doing a phenomenal job with incorporating and doing a good job with social distancing and making sure that families can access these places. The other thing, of course, is getting food delivered to our families' homes. This is a big element here. SNAP, as Hilary mentioned, there's some trials going on around the country, and a few other, DC actually just put in a request as well to try this out as well. So we're trying to try these innovative ways. WIC in particular, usually you would have to go on site to our WIC site, get tested and do all these different things to be able to access your WIC card or checks. But in this case, you're able to kind of go around that for this season, make a call, make sure that they recognize your risk, be able to get your checks delivered to your home. These are ways that we've tried to get around some of these nuances and these barriers that have been there for so long. But again, hopefully these continue moving forward. WIC by 2020, all of us should be using cards. This decreases stigma. This allows our families to go get in and out of the grocery store without having that boundary that's slowing them down and making them feel like, I don't want to continue using this because I don't feel safe when I'm using this card. These are things that are going to keep coming up, and those are ways that we've addressed it.
Yeah, thank you. How about you, Hilary? Any thoughts about improving access to food for elderly and isolated people?
I will just mention the need to continue supporting home delivered meals for people who are homebound. Ironically enough, when you look at food insecurity rates among older adults, as you get older and older, your food insecurity rate tends to go down. Why is that? It's because as people get more frail, we connect them with additional resources that have the unintended consequence of resolving the food insecurity. And in many cases, it's getting a home delivered meal service or getting an in-home support worker to help with cooking, et cetera. And so what we need to do is start thinking of these tools earlier in order to address food insecurity, and not just in the clinical setting to address physical frailty or other physical disabilities. Now, I will say that on one hand, and I will say on the other hand that these programs need to be supported financially, because these programs are being swamped with demand. And there are two ways to do that. There's a question about how do we help. Financial donations are always important. Food banks and these other home delivered meal programs are having to purchase a lot more food than usual. So yes, that helps. But even more importantly is using our platform as physicians and healthcare workers to advocate for policy changes that better support these programs that provide such a critical resource in our communities. As healthcare workers, we have a really important voice in saying access to food and access to the basics of healthy food are really important for keeping our patients healthy and safe. And we as physicians have to step up and be part of those conversations whenever there are attempts to roll back SNAP, to decrease funding for food banks, to decrease funding for home delivered meal programs, et cetera.
Your comments, Hilary, remind me of the largest food bank here in the state of Maine, the Good Shepherd Food Bank, which serves mostly rural communities, but also we do have urban poverty in Portland and a few of the other larger cities, Bangor and Lewiston. But last year they distributed 26 million pounds of food. 73% of it was actually donated by farmers, grocery chains, and people in the food distribution system. 17% was FDA supplied, and 10% was purchased with donations from individuals and foundations. So that 17% FDA provided, that's of course includes SNAP, but it also includes surplus food programs. Not always the healthiest food, but certainly calorically makes up a component of the food security. What are the chances, do you think, of expanding that approach from FDA? We go from 17% to 25 or 40% and expand the number of potential recipients?
So much to unpack there. I know we're short on time, so I'll give you just a brief answer, which is that what you're referring to is probably the Emergency Food Assistance Program, TFAP, which is run by the USDA and sucks up commodity foods and surplus foods and diverts them to food banks in order to distribute on the ground. There has been a lot of advocacy effort to do massive increase of that system so that food is not being wasted at restaurants, and particularly at farms and food manufacturers, and to divert that into the charitable food system. I'm sure that there is more that can be done, but these things are in the works. And the USDA has expressed at least some level of support for getting these programs scaled to address the massive need and the disruptions in the food supply chain that's leaving all of that surplus food in fields and factories.
Before I turn things back to Donna for her closing remarks, I want to challenge the two of you, and I'll try to participate as well. But what single recommendation would you make going forward in terms of changing policy, capitalizing on the political will that seems to be growing in the United States, that we are indeed all in this together, and influencing the policies that are going to be essential to take advantage of this crisis to create better food security in the future?
I can start that.
Kofi, you want to start?
Yeah, I'll be brief. So I think the biggest thing that I think about is we recognize at first that the disparity existed. The disparity is becoming more and more obvious as we continue to move on. So to be able to address a disparity like this, what we have to use is an equitable lens, an equity lens versus an equality lens, right? We cannot just do the same thing for everyone. We have to recognize that everyone is at a different point. And as a result, we need to really focus on specific inputs so that we can share some equal outcomes. That's going to require us to do a differential approach and not try to use one approach for everyone. I think we're doing okay in some elements, but to do this well, we have to be more strategic. And I think that's going to be a very important thing as we move forward.
Great. Thanks, Kofi. Hilary?
SNAP is the answer. SNAP gets economies going again. SNAP is proven to reduce food insecurity rates for households and for children. It is available in every county in the United States. It is able to scale massively. And if we can shift a lot of the demand into SNAP, it reserves the charitable food system, which is enormous, but is very small in size compared to SNAP. It leaves those charitable food resources for the people who are not eligible for SNAP. So if I could wave a magic wand, increase SNAP eligibility, increase benefit rates, support rapid enrollment for people who really need it right now, and make sure that it's reaching everybody in every community.
Great. Well, thank you both very much. This has been a very, very stimulating discussion for me. And now we're going to turn back to Donna for closing remarks. Thank you, Donna, for making it possible for us to address these issues today.
Wow. Oh my goodness. Thank you so much. This has been such an incredibly informative conversation. Hilary, if I had a magic wand, I would surely give it to you. I really appreciate all the insights from this panel and, about the impact of the pandemic, what it's having on food security crisis, and particularly among the most vulnerable in our societies. Bob, when you opened, the growing numbers that you shared at the beginning of this are just absolutely staggering. And the numbers and the disparities, I think that we're going to see in the coming year in the United States and elsewhere are going to shake us to our core. And it's going to require a massive effort of public and private sector responses, larger than I think anything we've ever seen in my lifetime. But we are seeing hopeful signs of efforts among the public-private partnerships, the philanthropic community through efforts like SNAP. And one thing is so clear to me today in hearing health professionals speak about this crisis is that physicians and other health workers like you need to be leading these discussions and policies. And then lastly, I'll just close with the many, many hopeful things that we're saying today to grab onto. And I really appreciated hearing about innovation and reaching more people and learning along the way on how to improve efficiencies. Because as Bob said at the beginning, if we get this right, we can have an impact on an issue for generations to come in very positive ways. And so thank you for sharing that. Thank you for all of those who joined us today to listen and be a part of this panel. And we hope that, that you'll join us again next week. We will be bringing in another group of experts in the field of medicine and science to discuss sexual and gender-based violence in the COVID context globally. So please join us next Thursday, May 7th at 1 p.m. And my heartfelt thanks to all of you.